Okay, good morning. So my name is Henry Tran. I'm going to be talking about post-prostatectomy incontinence today. I think there's a lot of conferences this week, so that's fine. That's great. So in terms of today, what I'm going to be talking about is just very briefly going over normal male continence, and then looking at kind of the incidence of post-prostatectomy incontinence, pathophysiology, some of the current treatment options available, and I really want to look at some of the newer technologies that are being developed currently. And then finally, I want to look at how do you bring a device from an idea to conceptualization. So we all know that basically in terms of normal male continence, the two primary components that are most important is your proximal urethral sphincter and your distal urethral sphincter. So in terms of your proximal sphincter, this is the component consisting of your bladder neck and then your prostate from the level of that level, from the bladder neck to the verumontanum. There's a lot of parasympathetic fibers in this area, and this is the component that gets removed at time of radical prostatectomy. In terms of the distal urethral sphincter, this is kind of the location from the verumontanum to the proximal bulbar urethra, and it's composed of a lot of urethral mucosal infoldings. You have your rhabdosphincter, your lysosphincter, you have your extrinsic skeletal levator muscles that help with compression, and then the supporting fascia in the area. There's also a lot of associated blood supply that's also very important for providing good continence. In terms of the rhabdosphincter itself, there's a component of slow twitch type 1 type skeletal muscle fibers, and they are important for helping to maintain your resting tone and continence, as well as your striated skeletal muscles. This is the surrounding area with all your levator muscles, your pelvic floor muscles, and they consist of your fast twitch fibers. And these are the muscles that are important for maintaining continence during times of increased abdominal pressure, so coughing, laughing, sneezing. In terms of innervation, you have your parasympathetic nerves, what provide your pelvic nerves, and your somatic pudendal nerves for innervation. So in terms of passive continence, I want to emphasize that one really important component they found is the lysosphincter. For example, after a TURP, when you do a TURP on a patient, the urine is kind of held at the lower limit of the prostatic cavity in that cavity aspect, and it's very proximal to the rhabdosphincter. After a radical prostatectomy, if you have any injury to the lysosphincter, even if you have an intact rhabdosphincter, you will still get episodes of incontinence. So it's very important for continence at rest. Having an intact rhabdosphincter does not necessarily guarantee that you'll be continent, and what it also means is that if you lose a rhabdosphincter, if your lysosphincter is intact, you may not be incontinent either.
Excuse me, what is the prefix of lyso?
I think it's all the smooth muscles surrounding in the area. That's my understanding of it.
The definition comes from the Greek word.
I'm not sure what the Greek word would be, but I'll definitely look into it. Yeah. So the rates and the incidence of post-prostatectomy incontinence kind of ranges from 5 to 20%. And the thing is, like, there's a lot of patient surveys looking at quality of life questionnaires. And so, when you ask patients, do they have any incontinence, the rates of leakage are reported from anywhere from 19 to 32%. But overall, the bother is still quite low. It is quite difficult to make comparisons, though, because there's a lot of different variables and there's a lot of different definitions in the literature for what defines incontinence. So is it the presence of any leakage, the total number of pads used per day, the pad weight, or is it mainly the degree of patient bother? So in terms of the pathophysiology, it's not primarily just a sphincter problem. There's three main domains of dysfunction. So there's bladder dysfunction, you can have obstruction, and you can also have sphincter dysfunction. So in terms of bladder dysfunction, there's different types of mechanisms, but you can have de novo bladder dysfunction after surgery from denervation of all those pelvic nerves. And then you can also have basically a pre-existing impairment secondary to bladder outlet obstruction and the age of the bladder. So in terms of the effect, you can have either overactivity or underactivity. So overactivity, you get detrusor instability, a lot of impaired compliance, and then underactivity obviously is impaired contractility, and you can have decreased bladder sensation and compliance as well associated with this. In terms of obstruction, it can primarily be from bladder neck contractures, and so you're having incontinence from that. And then finally, sphincter dysfunction. So you can have damage during surgery to your rhabdosphincter, pelvic nerves, all of your pelvic support structures. And then you can also have intrinsic sphincter deficiency, where you basically have an impaired ability to have urethral closure pressure and generate that normal urethral closure pressure that you have. You can also have a lower functional urethral length. What else also contributes is actually when you have a laxity of the posterior support behind the urethra, that kind of changes the configuration and shape of the urethra, and it basically makes it less effective in terms of generating urethral coaptation or closure. So this was a kind of an interesting study looking at what are the functional and anatomic differences in continent and incontinent men after radical prostatectomy. So they used urodynamics and MRI to assess basically 26 patients, 14 of them whom were incontinent and 12 of them whom were continent. And they basically measured things from urodynamics, including the mean resting urethral pressure profile. They found that they actually had a very similar urethral pressure between the two different groups and a very similar functioning urethral length. But in terms of the patients that were incontinent, they had basically an average pad usage of 2.4 pads per day. They had a bit of a lower bladder capacity. And again, they did not have that ability to generate increased urethral pressure when there was pelvic muscle contraction. So they looked at, in terms of the anatomic differences, they looked at things such as the bladder neck angle, the urethral length, the bladder neck angle, and then they also looked at basically the pelvic floor muscles surrounding the area. And so in terms of what they found that in incontinent men, the anatomic urethral sphincter length was actually 35% shorter. And they found that the bladder neck was much more funneled in these patients. And so, they found that the sphincter area primarily, in those patients that were incontinent, there was much more distortion of that area subjectively based on the radiologist's interpretation. So they felt that there was definitely functional and anatomic differences between continent and incontinent men after radical prostatectomy. So let's say you have a patient with persistent stress incontinence after surgery. How do you work them up? What are the steps that you take? So you look at, obviously we go through the history, physical exam, investigations. The things that are important to tease out on history include your voiding symptoms, so how much irritative and obstructive voiding symptoms are they having? What is the degree of bother for this? What are the previous prostate cancer treatments have they had? Have they had any salvage radiation, any other salvage therapies, and any other medical conditions that can also affect their continence? So diabetes, other neurologic conditions, previous other pelvic surgery, or other medication use. Physical exam, primarily very straightforward, rectal exam, neurologic screen. Investigations that you want to consider in these patients: culture, sensitivity of their urine, PSA, looking for any evidence of disease recurrence, checking their renal function, doing a basically non-invasive type urodynamics like PVR uroflow. And then you should also consider urodynamics in these patients. Cystoscopy is imperative to rule out any stricture disease, bladder neck contractures, stones, tumors, or other foreign body that may be predisposing. How do you treat these patients? So basically, we go through the conservative, medical, and then surgical treatment for these patients. Conservative, there's Kegels exercises, basically electrical stimulation has been reported to be effective potentially for very mild continence issues. And then time voiding, limiting your nighttime fluid intake, avoiding bladder irritants, all the good things for your bladder preservation. Medications that have been shown to have some effect: anticholinergics, SNRIs like duloxetine. So duloxetine is the presumed basis of the way it works is it increases your tone to your pelvic floor muscles by stimulating your ONEF's nucleus, and then alpha agonists as well. So surgical therapies included injectable agents, the male sling, and the artificial sphincters.
Henry, going back to that, is that duloxetine is not available?
It's not approved it's not FDA approved for the treatment of this. but some people have been using it, and there has been some reports that it is effective for mild post-prostatectomy incontinence, but it does take a long time to work. So in their study they looked at, it basically took at least about 4 months before they noticed any significant improvement. And what is interesting is in terms of the actual urodynamic factors like the post-forward residual and the maximum flow, there wasn't any difference in those
But
variables.
it's more of sort of historic interest because it's not
Mhm.
going to be, you know, like I'm sure the residents will indicate on what college exam, but in terms of practicality, it's not going to use it. Just like alpha agonists. Alpha
Yeah.
agonists in this patient population are toxic.
Yeah.
Like, you know, the incidence of significant hypertension from cold sinus medications is totally underreported.
Yeah.
And we say it, but the practice is anybody really use it.
Yeah, exactly. Yeah.
The
So
reason isn't because is it because it's of its side effects or because it's ineffective?
I would say it's ineffective, but it's more the side effect profile and that the systemic effects of an alpha agonist. I think that whole literature regarding the hypertension that can occur with alpha agonists is totally underreported.
yeah.
Talk to geriatricians, they would say, "What are you doing?"
Yeah, nobody really uses it. It's just primarily there for historical interest. But the duloxetine, they did show that basically for very mild incontinence, if you give it to them for over 12 weeks, their patients did note subjective improvement in terms of their incontinence. So that was an interesting study I did come across. In terms of the surgical treatments for these patients, though, who should get surgery? So who should go on to have surgery? Obviously, so if they have very bothersome incontinence, if they have true sphincteric deficiencies, and of course if their symptoms are lasting greater than a year or refractory to other conservative treatment measures, you should undergo surgery for these patients. The options for these patients include bulking agents, artificial sphincters, and again, male sling. The thing about bulking agents that's nice is that it's easy to perform, there's minimal morbidity, and you can utilize other treatment options if it fails, but the cons are that it's costly, and it's not durable, and there's question of whether or not it's truly efficacious. So these patients typically notice a significant improvement in the first couple of weeks after you do your bulking agent injection, but this wanes over time quite rapidly. They can have also a lot of side effects like retention, irritative voiding symptoms, UTIs, and failure, of course.
Is anyone doing this locally?
Not that I'm aware of, no.
I think there's a reason for that.
Yeah, when I talk to some people in the States, though, like a lot of people like to do this in the States, and then they can actually, a lot of them do this in their office, like they
It's
have
an
like a little office
procedure.
cysto suite.
It's relatively simple.
Mhm.
That's the best thing about it. But there have been some complications. One meeting I saw a rather horrid one, and it's definitely not your fastball as far as they
Yeah,
I
definitely.
mean, if anybody feels strongly that it's a good thing to do,
I think they use it mainly for fine tuning after they've had a sphincter or a sling, right? I agree with Dr. Sullivan, but
Mhm.
just because a lot of stuff that's done in the U.S. like TUMT and tuna, the percentages.
Yeah.
It's not. A lot of these are office-based, but if you look at the data,
Yeah.
you subject them
It's
to a
very
rigorous
weak data.
health technology assessment.
Yeah.
The payer in Canada ain't going to pick it up.
Yeah, definitely.
in Europe too, that people do not have, unless you're the professor or a member of the staff. Dr. Black can correct me if I'm wrong, but 10 or 12 years ago, things got done in office procedures that I found mildly upsetting because well-trained people were not getting access to operating. Well, yeah, you worked in a big center.
I don't know what happened in the
Didn't you? Okay. Well, I can tell you, they train an awful lot of urologists who don't get access to significant amount of surgical time, and so they are tending to, at least try, office practices that are questionable in my mind.
Yeah, so I guess moving on a little bit, looking at the artificial sphincter, historically, there's actually been a historic timeline for this sphincter device. So in 1947, Dr. Foley came up with like the first continence type device, and this was basically an external cuff that he placed around the urethra, and there was a pneumatic piston, and patients would basically control this manually. But the problem is, obviously, it also caused erections when the ring was inflated, so there's only a certain amount of time you can keep it inflated. But he did develop a surgical technique to place a ring around just the urethra and kind of exclude all of the cavernosal bodies. In 1961, Dr. Berry, he looked at it using an acrylic block, which you can see in this figure there, under the bulbocavernosus muscle, and basically it would just compress the urethra, cause permanent compression there. In 73, Dr. Kaufman basically had used a silicone-type gel prostheses, and again used that to compress the bulbar urethra. So there was a lot of problems with these initial devices, a lot of infection, erosions, and poor continence rates. And so, of course, in 1973, Dr. Brantley Scott, he implanted the first generation type AMS 721 device, and currently the AMS 800 is still considered the gold standard device for treatment of post-prostatectomy incontinence. Back then, he looked at 34 patients. They had about a 79% success rate. So the device back then was actually quite different from it is now. There's basically one pump within each scrotum. So inflation and deflation happened, as you can see here. So both pumps are used for inflating and deflating. And basically, there's very similarly, there is a cuff around the bladder neck, and there's a reservoir for the fluid. The initial problems with this device, though, was there was too much tubing, there was a lot of components, there was also high perioperative complications, obviously because we're just introducing it for the first time. And then you also have these spring-loaded valves, which led to high mechanical failure rates. There's been about 5 iterations of the device since then, and in 1983, the AMS 800, which is very similar to the current model that's out now, was instilled, and so it used a lot of better materials, so aerospace type engineering materials. They designed kinkless tubing to prevent the problems with cuff breakage and tube breakage. They used a pressure regulating type reservoir, and then in 1987, that's when they used the narrow back cuffing, which is good, as you'll see, for erosion and whatnot. It's improved that rate of erosions as well. So how does this pump device work? We all insert it in the OR, and we all know how to activate it and whatnot, but really what it is there's a resistor within the circuit, and that controls the rate of fluid filling around the cuff so that you don't have cuff closure that happens too quickly. Basically, when you want to deactivate the cuff, you basically have unidirectional flow from the pump to empty the cuff, basically going to the balloon. So the fluid goes from the cuff to the balloon and empties the cuff. And when you activate it, basically you have continence that's maintained. And again, the very nice thing about this design is that the resistor in the circuit allows for slow cuff filling. So how well does the sphincter work? What is the overall rates of success? What if they have pre-existing overactive bladder? How does it work in that setting? And what if they've had previous radiation? So, there's obviously variable definitions of success that we talked about, and variable degrees of incontinence across the different studies. But as you can see here, basically selection of case series showed that the overall patient satisfaction is actually quite good. 73 to 90% of patients are satisfied with their device. So in terms of patients that have overactive bladder, Dr. Lai looked at 130 patients that had preoperative urodynamics and subsequent artificial sphincter insertion. Basically, they found that there was no difference in the continence outcomes in those patients that had pre-existing overactive bladder. So 70% of those patients that had stress incontinence and overactive bladder preoperatively continued to have some overactive bladder symptoms after their operation, and 23% of patients that had pure stress incontinence did develop de novo overactive bladder after the sphincter was inserted though. But they did feel that pre-existing overactive bladder should not preclude the artificial sphincter being placed, and they felt that it was a separate entity. They did treat patients with anticholinergics afterwards, and they did do much better. After radiation, so there's kind of been some mixed outcomes in studies that looked at patients that had radiation versus non-radiation. So basically Dr. Walsh in 2002 basically looked at 76 patients with no radiation pre-artificial sphincter insertion versus 22 patients that did have radiation. He felt that there was a much higher rate of complications in those that were radiated, so they had more atrophy, erosion, infection, and their rates were 41% versus 11%. But what he did find, though, was that the patient satisfaction did remain high despite those complications, and these patients actually would still recommend or still undergo artificial sphincter insertion despite having experienced these. Dr. Lai looked at a larger series of irradiated patients, and he actually found that there was potentially no difference in complication rates and continence outcomes for these patients. The thing is, with these patients that have had previous radiation, what is really important is that you recommend potentially leaving the sphincter deactivated for a longer period of time after you implant the sphincter, and potentially you might want to use a lower pressure type reservoir so there's less urethral compression.
One of the things is, though, you're going to go into transcorporal, but with the radiated patient, it depends on the quality of the tissues in terms of atrophy.
Yeah.
And then that's going to determine cuff size. Like I'm just a reader of prosthetics. I'm not doing that. Rick's the only one in the room here who does any prosthetics. But the complication rate is still quite high, even with the Turns group, doing ongoing complications. They've demonstrated that.
Yeah, for sure.
Have you done any post-radiation cases?
I don't do sphincters anymore. I just do slings, Continence, and penile prosthesis. So Dr. Nyberg is on one here, other than Danny Rappaport. But I'll do slings and post-radiation.
Did you find a difference between external beam, post-external beam radiation and seed implant?
I haven't done any in the seed implants. Only the ones that have had external beam following that. But there's a difference here. Post-radiation always do for primary
So looking at some of the modifications that we do for artificial sphincter implantation, so transcorporal. So basically, if you're doing revision surgery and, like we just said, radiation, for example, basically when you do a transcorporal approach with the cuff, you have more bulk around the urethra. But you have to warn your patients that they will have some erectile dysfunction after this because you're going through the corpora, obviously. Other modifications that have been tried, tandem cuff, so basically placing a second cuff around the urethra. This can be done for patients that have severe incontinence, but there is much higher complication rates. Basically, Dr. Elliott looked in 2007 looking at tandem transcorporal cuff placement, and he felt that this was an option if there's impending erosion of the pre-existing sphincter and whatnot. It can be something that can be tried. Not very commonly done, though. Nocturnal deactivation. So this idea, Dr. Boone presented this in 2001, and he looked at patients that had nocturnal deactivations versus those that did not. And of course, when you're sleeping at night, if you lower the pressure around the sphincter and the cuff, they found that there was much lower risk of urethral atrophy, and in this group, so 10% versus 21%, and that's kind of been something that Dr. Nigro, I know, tells his patients to do, is nocturnal deactivation of their sphincter. So what about male slings after artificial artificial urinary sphincter replacement for urethral atrophy? So Dr. Christine basically looked at this and found that if you look at patients that have actually a partially or a functional external sphincter during systole, they may benefit from having a salvage advanced sling placed in the setting of a urethral atrophy. And then in terms of sphincter insertion after a failed male sling. There's not a lot of good literature or long-term data on this, but the series are out there do report that this is feasible, that patient satisfaction is still high, and there hasn't been any significant complications. Obviously, long-term data is still waiting, but if you put a sling in a patient and it doesn't work, they have ongoing incontinence, you can consider an artificial sphincter placement in these patients. What are some of the contraindications to sphincter placement? Obviously, so dexterity and mental cognition is important because of the device itself, being able to utilize it. If they have unstable urethral strictures, if they require repeated transurethral surgery, so bladder tumor surveillance and whatnot, infection, so active infection, and then bladder dysfunction, that's something that we mentioned earlier, that is mainly a relative contraindication. Some of the complications that can happen include infection, erosion, recurrent incontinence, so from either device failure or urethral atrophy, and then you can also get urethral strictures. In terms of the infection itself, it's about a 4.5% incidence, and the most common organisms include your staph. They may not actually show typical infection signs of white count, fever, purulence, but you should be aware if they have new onset pain. So typical symptoms: erythema, edema, pain in the perineum or pump area. You basically treat it by removing the device and replacing it after it's healed in a couple months. Now, there's been some literature reports of salvage of the prosthetic device using antibiotic irrigation solution, a 7 antibiotic mixture, but it's been reported, but it's definitely not common practice. In terms of erosion, there's about a 12% rate of erosion, and in contemporary series, it's about 3 to 12%. Basically, treatment of erosion would be device removal, urethral repair, and you can consider a urethrogram to make sure that the urethra is healing well, and you basically try to reimplant the sphincter at a different site. Mechanical dysfunction. So basically, since the introduction of narrow back cuff, the rates of mechanical failure have decreased significantly. If the device is quite new, so less than 3 years old, you can primarily just replace the component that failed, but after that, you should probably replace the entire device. Nonetheless, the artificial sphincter is still considered the gold standard. It's the most widespread and effective option that's available in the market currently. So if the sphincter is the gold standard, why do we need other surgical options? So again, we talked about the sphincter requires manual dexterity, and then the complications associated with the sphincter device can be actually quite substantial. So revision rates are quite high, mechanical failure rates are high, there's a risk of infection and erosion. The slings were designed to try to overcome some of these disadvantages and also mimic physiologic voiding. So basically, the mechanism of how slings work is not just to increase the urethral resistance, but it's also to realign the sphincter complex itself. So basically, Dr. Barry, Dr. Kaufman, they described kind of the first type slings. They had lots of complication rates and low success rates, but who should we consider for slings currently in this modern day? So typically, the indications would be mild to moderate stress incontinence. Patients have no periurethral fibrosis. They can generate adequate voiding pressure. And in patients that don't really have the manual dexterity for a sphincter device, you can consider slings. The first ones that came out commercially available in the current generation were the bone-anchored slings, so Invance. This was designed by American Medical Systems. Basically, there's a silicone mesh-type device for bulbourethral compression, and then they use titanium screws to secure the device to the pubic ramus. And so, pad-free rates were about 36 to 65%, but there's some complications associated with it. So a lot of pain, retention, and then infection was also another thing. And then bone anchoring dislodgement. That was rare, but did happen. Since then, it's basically declined in popularity, and it's basically been completely taken off the market. There are a new class of readjustable sling systems, and one of these devices, which I will present, is the Argus sling. The Remex sling is the other one that's readjustable. Basically, you can implant it either using a retropubic or transobturator approach. You can actually adjust the sling tension. Reported dry rates in the literature are 65 to 90%. There is some complications though, typically just transient perineal pain, and then erosion into the urethra has been reported. If they do not do well with an Argus sling, you can put an artificial sphincter, and that has shown good results. The thing with these slings though is that you may have to have multiple tension adjustments in order to achieve the good clinical outcome that you want. Basically, this is the sling device there, and typically intraoperatively you can adjust the sling to about a leak point pressure of 45 centimeters water. So you can either use a arterial catheter to do that measurement, or you can basically hang your solution at 45 centimeter water pressure and just wait for the column of water to stop instilling. They looked at 100 patients with moderate to severe stress incontinence that used the Argus sling. They followed them for about 2 years, and basically 16% of these patients had to have their sling removed for erosion or infection, but 80% of them were dry. Basically did very well, and the authors of this paper supported it as a good first or second line treatment, and they did have a cohort of patients that were radiated previously, and they did well with these types of slings. The advanced sling, this is the basically the sling that has had the largest group of evidence and experience to date. Basically, again, it helps to support that posterior urethra into the normal pre-prostatectomy position. Very preconditions that basically help improve success rate would be like good mobility of the sphincter region, good residual sphincter function, and reported dry rates are 60 to 90%. There can be some complications, again, transient postoperative retention, wound infection, UTIs, pain, and then very minimally erosion and infection. There has been an inverse relationship shown between incontinence severity and sling success. So the more incontinent you are, less likely the sling may be helpful. Previous radiation is listed as a negative predictive factor, but patients can still undergo sling placement, and they have shown that patients with some detrusor overactivity, they actually contradictory to what you would think, they actually did have some improvement in symptoms after sling surgery. How can we improve the success with these sling treatments? Is there kind of an optimal patient type? This was looked at, and basically they found that patients that were ideal candidates for slings had mild to moderate stress incontinence. They had basically an ability to volitionally contract their external sphincter. There was no previous history of radiation and cryotherapy, no previous history of anti-incontinence surgery, and then they could generate detrusor contraction. Patients that had low PVRs. So this was their cohort, and of course, like, these are the ideal patients, and I would imagine that most patients with this type of picture, doesn't really matter what type of sling you put in, they would probably do much better than those that did not have these types of factors. So in terms of new development, so the AMS 800 is really the gold standard sphincter, and the advanced is the most commonly used male sling. There has been good efficacy. And one other thing I want to emphasize, again, re-emphasize, is that the sphincter can be used after sling failure, and the sling has been used even in post-sphincter in specific cases with variable success rates. So what else is available in the market nowadays? So there's ProACT system. This was basically introduced in 2001, and basically there's 2 balloons that get inserted up alongside the bladder neck, and they basically help provide urethral compression to help achieve continence. Dry rates have been reported up to 60 or 70%. There are some similar complications, and again, you can still consider the sphincter if ProACT fails. The nice thing about this I've seen is that they can do this a very minimally invasive way. Basically, you just need a fluoro suite, and you can check the placement of the balloons in your fluoro suite, and you can place it in about 15 minutes once you've been doing it for a long time. The Virtue sling is kind of a new type sling. It's basically, this is a very recent paper that was published looking at this device. There's 2 different mechanisms of action for this. There's a transobturator component, basically relocates and realigns the urethra, and then a pre-pubic component for the actual bulbourethral compression. And basically you adjust the tension to basically achieve the active continence that you wish to have. They did a basically clinical trial looking at 2 different multinational clinical trials. The second trial is different from the first one, primarily because they use a new fixation mechanism to prevent the early loss of sling efficacy. They looked at primary endpoints such as 24-hour pad weight, patient global improvement, and basically they listed subjective success as patients that had very much or much better improvement at 12 months, and the objective success is those that had 50% reduction in pad weight use. In terms of the results, those patients that underwent fixation, the new method of fixation, did much better, and the subjective success rates did not change whether you had mild incontinence, intermediate, or severe incontinence. That was one nice thing after they basically refined their method of implanting this sling, is that they found that the success rates were much better, and it was very equal amongst the different types of degrees of severity of incontinence. So the most common complications were perineal discomfort, transient paresthesias. And so basically this initial small cohort did show good efficacy and safety, but longer follow-up is needed. So this may be a device that will be growing in popularity. The Flow Secure system is kind of developed by Drs. Craig and Mundy. It's kind of looking at very similar type of design to the artificial sphincter, the AMS 800, but what it does have is an additional balloon, which they call the stress release balloon. And the way this works is that when you have increased intra-abdominal pressures, the idea is that this squeezes on the second balloon and generates added urethral cuff pressure to prevent incontinence. And what the authors state as a benefit is that normally during rest, they can provide a lower type of urethral cuff pressure. So they think that there might be lower rates of atrophy and whatnot, but you know, there's a lot of mechanical failure with this type of device, and a lot of infection as well associated with it. The Zephyr is another device kind of commercially available in 2009. It's a one-piece device, which is the stated advantage of this device. There's a control unit consisting of the activation button, the hydraulic circuit, and the compensation pump. It's one unit. But the short-term data for this actually has been quite disappointing. So, you know, there's a lot of plethora of like slings and sphincters on the market right now, variable efficacy stated, and currently the AUS, the AMS 800, and AUS-like devices are still kind of far from ideal. What other types of advancements or developments exist? So there's these actually really interesting things out there right now. So electrically activated polymers. So basically, these are kind of nanotechnologies that can try to stimulate biological sphincters. So it consists of a material that has a capacitor with some electrodes, and it's basically a type of elastically deformable but incompressible polymer. And it basically can change shape based on the electrical charges. So it actually is like an artificial muscle, basically. And there is this company in Switzerland looking at this. They've developed a preliminary system called the ARTIS system. There is basically consists of a modular unit with 2 compression cuffs that operate in kind of piano mode. So what they mean by piano mode is there's periodic compression along the urethra for this cuff device. And basically what the authors state is the advantage is that you're not compressing one part of the urethra constantly. You're basically changing where you're compressing the urethra, and so you have less tissue ischemia and presumed lower rates of atrophy will be present. So there's basically a control unit, power unit, a user remote, and then a clinician remote as well. This is not yet commercially available, and so we will have to see if this has any popularity once it comes out. Shape memory alloys. So basically these are materials that look at temperature dependent shifts within a very refined crystal structure, and they can change shapes based on this. These 2 technologies, EAP, SMAs, are still not commercially available because there's obviously high manufacturing costs with these devices. There's high energy consumption, so that's one thing that the developers have not yet figured out is how do we provide the basically power to power up these devices over long periods of time. And basically there's not a really good response in these devices with sudden changes in intra-abdominal or luminal pressures. stem cells. So very quickly looking at stem cells. Basically, previous periurethral bulking agents showed poor efficacy. What about stem cell therapy? Is there any efficacy with these? So this was a study done in Japan looking at basically stem cells being injected periurethral. So we know that multipotent stem cells, they have the ability kind of to proliferate and change into different cell types. We can obtain these stem cells from adipose tissue, skeletal muscle, and also bone marrow. What is nice is that the adipose tissues, they have much more potent stem cells compared to bone marrow. So this was a very small study looking at only 11 patients. And basically all of these patients had persistent stress incontinence greater than 2 years after radical prostatectomy and after holdup. This was a 3-hour surgical procedure that they described. They basically took some abdominal fat, harvested a lot of these cells, put them through a commercially available cell system, and basically refined a very concentrated culture of cells composed of autologous stem cells, endothelial smooth muscle cells, and then macrophages and whatnot. And then they injected it into the external sphincter. They looked at these patients and followed them up to about 1 year's time, and they looked at the degree of incontinence measured by a 24-hour pad test serially over 4 days consecutively. And they looked at the difference between baseline and at 12 months. They looked at secondary outcomes as well, looking at urethral pressure profiles, subjective symptom, and quality of life scores. And what they found was that in these patients, 8 out of the 11 of them did notice a daily decrease in terms of the leakage volume, changed 40% or so in these patients. And these same 8 patients had significant improvement in their subjective scores. And when they did do an ultrasound to the area, they saw increased blood flow to those areas that had previously injected. So, they concluded that this was a safe and feasible option. But, what I want to know is, what are the costs of this? And basically, would these patients have improved without injection anyways? What was it that was special about these 8 patients that made them have a response to this stem cell therapy? So basically, now I just want to look at the last part of my talk, which is basically looking at when you have there's a lot of different biomedical devices presented for the treatment of post-prostatectomy incontinence. Urology has been, it's a specialty where we've had a lot of technological innovation. How do these new ideas become realized? And so this was a very good paper that looks at regulatory approval for FDA approval in the United States. So typically what happens in this model is there's a physician or some type of engineer, inventor comes up with an idea. So a device solution to meet some clinical challenge. And basically they initiate a patent process on the side, and he starts building these preliminary device prototypes. And so typically they use what we call angel investors for this. So the preliminary device bench and animal testing, this is all done with their own funding from either friends, family, or themselves. And that's the definition of the angel investor. And then obviously this device undergoes further developments. So you have a team of engineers that you bring on and physician advisors, and you basically go through the classic engineering principle of design, build, test, and then go back and redesign until you have something that works better. This is a very costly and time-consuming process, obviously, and typically you get your funding at this point in time. That's when you start to look into venture capital firms and have equity financing for this. Very few academic centers actually have the intrinsic capability to develop a device beyond early prototype. And in that instance, what they do in the States, in the US, is that the intellectual property of the device is out-licensed to an existing company or some type of startup company so that they can actually take your initial device and develop this further. There's this US Congress Act, basically, that still assigns all of the intellectual property rights back to the primary academic medical center. And so then these devices undergo regulatory approval. And in the United States, it's the Center for Devices and Radiological Health that regulates all of these medical devices. And they look at the devices in terms of 3 different risk groups. So Class 1, Class 2, and Class 3 devices. Class 1 devices are your lowest risk devices, and basically formal FDA review is not required prior to market introduction. Class 2 type devices would be things that are
significant higher risk. So special controls are needed, like post-market surveillance have to be in place. There has to be certain performance standards that are regulated, and design controls, for example, are required. And for Class 2 type devices, FDA clearance is needed. And usually, though, you can do this using bench and animal testing alone. Class 3 devices are your highest risk. So, for example, heart valves, pacemakers, coronary stents, and basically FDA approval of the pre-market notification application is needed before you can have legal marketing of this device, and they also need it to be backed up with clinical data. There's two different phases for development of these Class 3 devices, so the pilot and the pivotal phase. The pilot phase basically helps to establish safety and aids in the pivotal trial design, and overall it's typically a quite long, arduous, and expensive pathway for the development of new medical devices, so many years, millions of dollars. So in conclusion, I just want to say that post-prostatectomy incontinence does have a significant impact on patient quality of life. There is an extensive diagnostic workup that's needed before you actually intervene, and basically have to make sure that these patients are appropriate for intervention. The AMS 800 still remains kind of the gold standard for treatment. There are newer devices in development, but the innovation within medicine is kind of a slow, arduous, and quite extensive process. And so with that, I'd like to thank Dr. Goldenberg, Dr. Rappaport, and Dr. Kwan for their contributions to the slides. Thank you very much.